Ladies and gentlemen, I'm Dr. Kevin OBENG-Marnu, a practicing neurosurgeon.
This is Dr. Kevin OBENG-Marnu, MD. Welcome to my channel. Subscribe, like, comment, and share. And God bless. Thank you. Welcome back, ladies and gentlemen. Welcome to Dr. Kevin Marnu's USMLE. Today is the 16th of October 2021. And it's a Saturday. Thank God it's a Saturday. This is my page. You can take some time and visit me anytime. And this was our last video, episode 3, the Porphyria Cutanea Tarda of the 100% USMLE board classic exam questions that we solve here. And for all those who do not know me, my name is Dr. Kevin OBENG-Marnu, and you can WhatsApp me and also join my pages. And yes, we do a lot. And I'm into medical consultancies and, online education, USMLE, mentoring, etc. Okay, and I'm also a practicing neurosurgeon. This is my page, my personal neurosurgery page. Y'all can take some time off and visit me here on my page. We do a lot here as usual. So without further ado, let's get into it. And for all those who love Instagram, yes, y'all can find me here. And yes, let's look at what we have for today. And yeah, I do a lot of teaching. USMLE step 1, step 2 CK, step 3, everything, everything we can help and support your dreams. There's a lot of teachings that we do, a whole lot, and anytime you wish to have a lesson with me, feel free to message me. There's a whole lot, whole lot. Okay, all right, so let's get into the business for today. And today we're gonna do something very nice and as usual, very high yield. So this is the 100% USMLE classic board exams. Okay, so let's look at it. Let's get going. Okay. An 8-year-old boy in the clinic has upslanted eyes with epicanthal folds, a flat nasal bridge, a transverse palmar crease, a subendocardial cushion defect, and intellectual disability. A defect in which step of cell division is most likely cause of the patient's defects. Okay? And here are the options. Option A, meiosis 1 anaphase. Option B, meiosis 1 metaphase. Option C, meiosis 1 prophase. Option D, meiosis 2 anaphase. Option E, meiosis 2 metaphase. Option F, meiosis 2 prophase. All right, I love this question because this question is like a 3-step question. You need to know 1, your cell biology, 2, your genetics, 3, your pathology in order to answer this question. And the boss love it. Okay, also physiology, your anatomy. You need to know all. Okay, all right, so let's get into it. So I'll start with the cell biology. For all those that follow me who are IMGs and above 35, 40 years of age that still have the dreams of acing the USMLE boss, here we go. So let's start from the beginning of it all. That is the cell stages. Okay, so this is the cell stage. We have the G1 phase, the S phase, the G2 phase, and the M phase. This is very, very high yield. Okay, the interface consists of the G1, the S phase, the G2. Okay, without the mitosis. The mitosis phase is different. So this is the interface. The interface is G1, S phase for the DNA replication, and the G2 phase. And the mitosis is where you have your prophase, your metaphase, your anaphase, and your telophase. Okay, so we'll be looking at this systematically. And this is very, very important also for the boards, especially pharmacology questions, the cancer drugs, cancer medications. Okay, so cancer therapy that inhibit these cell cycles, you have to know them. This is super high yield. Okay, so let's start with the mitosis phase. We have the microtubule inhibitors, that is the taxanes and the vinca alkaloids. Taxanes like your paclitaxels, okay, that inhibit what, or it stabilizes the microtubules. okay? And also the vinca alkaloids inhibit the production of microtubule. That is your vincristine, your vinblastine, etc. All right? And side effects, of course, you should know the side effects of being peripheral neuropathy. Okay? And also we have the cell cycle independent drugs, whereby we have your platinum drugs, your cisplatin, all those platinum drugs, and alkylating agents like anthracyclines, like your doxorubicin, adrimycin, busulfan, dactinomycin, procarbazine, etc. So from the resting phase, which is this G0 phase, we have the G1 phase. And G1 phase heading towards the S phase, of course, we have regulators. The RB tumor suppressor genes and the P53 tumor suppressor genes. That's G1 restriction point. And this is very, very important clinically. Retinoblastoma disease, that is RB tumor suppressor gene mutation. That is the 2-hit hypothesis for all those who know what I'm talking about. And we also have the P53 in Lee-Fromini syndrome, the SBLA, the sarcomas, the leukemias, the breast cancers, okay, and the Fanconi anemias, what so not. Okay, so DNA synthesis in the S phase. All right, and we have drugs that inhibit the DNA synthesis. We have the anti-metabolites. The anti-metabolites, of course, your 5-fluorouracils, your azathioprines, your methotrexate, etc. Okay, and we have these drugs called the topoisomerase inhibitors. Okay, it's 1 and 2. Topoisomerase 1 and 2, because topoisomerase 4 is the DNA gyrase, okay, and that is going to be your ciprofloxacin, your fluoroquinolones. But this is the 1 and 2. The 1 and 2 is your etoposide, your topotekins, okay, and that specifically inhibit the S phase and also can inhibit the G2 phase. So S phase to the G2 phase. And my favorite drugs, everybody say, hey, Dr. Kevin, you love this drug so much. Yes, I love it. Bleomycin, G2 phase. Bleomycin I love because it can also inhibit the M phase as usual and inhibit the G2 phase. And bleomycin, we can use that for seminomas, etc. And it can cause pulmonary fibrosis, okay? Pulmonary fibrosis. So this is a free radicals causing pulmonary fibrosis. And it's very important because busulfan can also cause pulmonary fibrosis, and also amiodarone can cause that. So this is very, very and super high yield, cell cycle anti-neoplastic medication. So you have to know that and all the side effects. So this was just by the way, just to give you a bonus here with the pharmacology. All right, so let's look at it. Your DNA duplication or replication takes approximately 8 hours in the S phase, and the G2 phase, of course, the cell growth too, approximately 4 hours. And we have 1 to 2 hours in the M phase, whereby we have the prophase, the metaphase, the anaphase, the telophase, and the cytokinesis. Okay, and also we have the G1 phase taking approximately 10 hours. And of course, we have the G1 checkpoint. All right, so let's take notice of this, okay? So, yes, here's a recap of everything. We have the prophase, we have the prometaphase, we have the metaphase, we have the anaphase, we have the telophase, cytokinesis, and the interface. Okay, so take notice of this properly. All right, so I'm going to take it one after the other and teach you systematically what it all comprises. So in the interface, you can see that, of course, there are 2 pairs of centromeres formed, and we have the chromatin, we have your nucleolus and your nuclear envelope and your plasma membrane. Okay, so let's look at it clearly here. Of course, we have the centrosome, which consists of the centriole and the microtubule being formed. Whereas we have the nucleus, and the nucleus consists of the nucleolus. If you can see, this is the nucleolus in the middle there. And we have our nuclear membrane. Nuclear membrane is there, and the DNA is like a thread, a thread-like DNA. Okay, so take notice of this. In the interface, this is what we have in the beginning. Okay, and I've told you the interface runs from the G1, the S phase, up to the G2 phase without the M phase. Okay, so this is the interface. So now we're going to move to the M phase, which is the mitosis phase. Okay, so here is how your interface looks like. Okay, and now with the mitosis phase, whereby you have the first one being the prophase. With the prophase, what happens is that the nucleolus disappears. Okay, here, no nucleolus. Okay, we used to have a nucleolus here. Now it's gone. It's totally gone. So nucleolus disappears. Chromatin condenses Now, instead of the thread-like, DNA, it now condenses into real chromosomes. Okay, so condenses into chromosomes, and there's also separation of the enterosomes, and there's formation of mitotic spindles, which is very, very important here. You can see the blue spindles here. Formation of mitotic spindles. There's also one here at this end. Okay, so take notice of it. So we have the prophase. Chromatin condenses into chromosomes, nucleus disappears, and mitotic spindles are being formed. Okay, and yes, of course, you can see the mitotic spindles being formed, and your nucleus disappears, and we have the chromosomes intact. Now, let's go to the next step, being the pro-metaphase. So pro-metaphase, okay? So with the pro-metaphase, now what happens is that the nuclear envelope itself disassembles. The nuclear envelope itself, it begins to disintegrate, okay? And what happens is that the chromosome forms two kinetochores at the centromere. And what happens again is that microtubules attach to the chromosomes. So you can see the elongation of the microtubule spindles attaching itself now to the chromosomes in the middle. Okay, so you can see this in this clear picture here. All right, and of course, this is as a result of the nuclear membrane disintegrating. So now the microtubules can penetrate. So after that, we have the metaphase. The metaphase is when the chromosomes align in the metaphase plate. Okay, so the metaphase is going to align in the metaphase plate. So as you can see, it aligns in the middle, called the metaphase plate, like the equator. The next step, which is very important for our discussion today, is the anaphase. The anaphase, unattached microtubules push against each other to elongate cells, and the chromatids separate towards opposite poles. So we can see the chromatids moving now to the left and also to the right. All right. So we have anaphase 1. In anaphase 1, homologous chromosomes move to the opposite poles of the cells. Take notice. And in anaphase 2, we have the centromeres dividing, and the chromatids move to the opposite poles of the cells. Not the chromosomes, now is the chromatids. You can see the difference right there. This was the chromosomes. Two sister chromatids, okay? Sister chromatids. But now here is the chromatids moving. That's the anaphase 2. In all situations, we have metaphase 1, metaphase 2, prophase 1, prophase 2, anaphase 1, anaphase 2, and all that. We'll be looking at it later. Okay, and now we have the telophase. With the telophase, what happens is that the spindle fibers start to disassemble. They break apart, one piece at a time, and finally disappears. Okay, so you can see the breaking apart of the spindles. Okay, the breaking apart of the spindles and disappearing. So in telophase, new nuclear envelope forms. Chromosomes unfold back into chromatin. Nuclei reappear. Cell continues to elongate or elongate. All right, however you want to pronounce it. Okay, take notice. So we have the telophase here. We have elongation of the cells, and we also have, yes, and now we have the cytokinesis. The daughter cells divide. There's now a division. Take notice. With the cytokinesis, what happens is that a contractile ring creating a cleavage furrow is formed in the middle, and that splits it. And now we have a completed nuclear envelope surrounding the decondensing chromosomes. Cytokinesis. So the furrow now continues to deepen. It deepens and eventually split two daughter cells. So there's a formation of two daughter cells. All right, as you can see clearly here, cytokinesis. All right, so you can see that in this image, contractile furrow being formed, and eventually it's gonna split. Same, very beautiful, huh? How beautiful nature is, ladies and gentlemen. Now, somebody will ask, Dr. Kevin, what's the difference between mitosis and meiosis? I forgot. I learned that in medical school. I forgot. Okay, now let me remind you. Okay, mitosis and meiosis. Okay, now mitosis is 4 stages in total. It's a 4-stage affair. Okay, whereas meiosis is 8 stages in total plus the interphase. It happens in germ cells. Meiosis happens in somatic cells. Mitosis. Purpose is cellular proliferation. Mitosis. Purpose is sexual reproduction. Meiosis. Produces 4 haploid daughter cells. Meiosis. Produces 2 diploid daughter cells. Mitosis. Chromosome number remains the same. So, as a result, genetic variation doesn't change. Remember, chromosome number is halved in each daughter cell, meiosis. And as a result, there is a whole lot of genetic variation. It increases. Take notice of this, please. If you didn't get it, pause the video, rewind, and listen to it again, and continue. Okay, and this is same for both mitosis and meiosis, okay? Both produce new cells, of course. This is, mitosis is what? Is diploid, and meiosis is haploid. They all have similar basic steps. They start with a single parent cell, of course. They all does. And now, look at this clearly. So with the mitosis, we have the prophase, we have the metaphase, anaphase, and the telophase. What happens is that the chromosome duplicates. So duplicated chromosomes, that is 2 sister chromatids. Now we have duplicated chromosome aligned at the metaphase plate. Okay? And with the anaphase and the telophase, the sister chromatids separate and now move to the opposite poles like we've just discussed. And the end result is that you have 2N, 2N. Okay, being 2 diploid daughter cells. Over here, we have meiosis 1 and meiosis 2. Okay, so we have a tetrad. That's 2 pairs of sister chromatids. And now the tetrads align at the metaphase plate in metaphase 1. Homologous chromosomes separate and move to the opposite poles. 2 haploid daughter cells are formed. And in meiosis 2, we're going to have 4 haploid daughter cells. N. That is the end result of meiosis. Take notice. Again, if you didn't get that, let me show you the simplified version. So in mitosis, you have 2N. Now going through the processes of prophase, anaphase, metaphase, etc. And now the end result is a 2N, 2 daughter cells, diploid. A meiosis is similar, but we have meiosis 1, whereby we have 2 haploid, and meiosis 2 gives us a 4 haploid. It's halved. Okay, so this is 1N, being 23 chromosomes, 23 chromosomes, 23 chromosomes, 23 chromosomes, whereas this is 46 chromosomes, 46 chromosomes for the mitosis. Similar, so you can see mitosis here is a 46 chromosome diploid. And this is haploid, 23 chromosomes, meiosis. Take notice. And they both have maternal chromosome and paternal chromosome to start with. So similar. Mitosis. Okay, we have the interphase, the prophase, the metaphase, the anaphase, the telophase, and the cytokinesis. Okay, I think we have discussed all this previously. And until we have the production of the daughter cells. Meiosis are in 2 stages. We have the meiosis 1 being the segregation stage. Okay, so homologous pairs are separated, reducing chromosome number by half. Okay, so that is the prophase 1, metaphase 1, anaphase 1, telophase 1. So synapses for crossing over and independent assortment in anaphase 1, which is very important for our question today. Okay, and it happens in the germ cell in gonads. Whereas in meiosis 2, sister chromatids are separated, producing 4 haploid gametes. Okay, as a result, we have the prophase 2, the metaphase 2, the anaphase 2, and the telophase 2, ladies and gentlemen. So let's recap everything. Okay, we have the prophase 1 and the prophase 2. Okay, so with the prophase 1, as we have already said, the chromosomes condense and the nuclear envelope breaks down, crossing over occurs. Prophase 2, a new spindle forms around the chromosomes. Metaphase 1, pairs of homologous chromosomes move to the equator of the cells. Metaphase 2 chromosomes line up at the equator. Anaphase 1, homologous chromosomes move to the opposite poles of the cells. Anaphase 2, centromeres divide. Chromatids move to the opposite poles of the cells. Telophase 1 and cytokinesis. Chromosomes gather at the poles of the cells. The cytoplasm divides. Telophase 2 and cytokinesis. A nuclear envelope forms around each set of chromosomes. The cytoplasm divides. Okay, so take notice of this. This is everything that we've talked about. So ladies and gentlemen, the cell biology aspect is done. So now let's look at the question once again and see the pathology aspect of it, or the genetic aspect of it. An 8-year-old boy, of course, in the clinic has upslanted eyes. So now we have to diagnose with epicanthal folds, a flat nasal bridge, and a transverse palmar crease, and a subendocardial Cushing defect, and intellectual disability. Okay, so ladies and gentlemen, this is Down syndrome. Okay, Down syndrome is very common congenital chromosomal anomaly, okay, which is found in the whole world, worldwide, every country. Okay, so the condition occurs when there is an extra copy. That's a trisomy. It's a trisomy 21, ladies and gentlemen. We also have trisomy 13, which is the Patau, and I'll be doing the Patau video next time. We also have the Edwards syndrome, which is trisomy 18, and the board really love these trisomies. 13 for Patau, 18 for Edwards syndrome, and 21 for Down syndrome. It's all over the boards. Okay, so let's see. This baby has an upslanted palpebral fissure, like they said in the question, and a flat nasal bridge. Okay, also have a single palmar crease. Okay, sometimes they may have two, called the simian crease. Clinodactyly of the fifth finger is like a bent finger. It's bent as a result of bone deformity. Also, they have a nuchal folds. So the nuchal folds at the back of the neck, and they also have a short neck and hypotonia. Okay, so you can look at this: mental retardation, low set ears, abundant skin on the neck. That's the nuchal folds. Okay, they have a short neck. A lot of babies with chromosomal disease have short neck. One example is the Turner syndrome. With the Turner syndrome, it's 45X0, and normally it's in female. Okay, normally it's in female. They have a short stature and a webbed neck. So that is different, okay? And single palmar crease. This is classic for Down syndrome, okay? Intestinal stenosis. All Down syndrome patients end up with duodenal atresia. Whenever you read a question and you see that they're heading towards the diagnosis of Down syndrome and your answer options have duodenal atresia or intestinal atresia or stenosis, please choose that answer. That is the answer, okay? And most of them end up with Hirschsprung's disease. So if you see something, it is Down syndrome, and they say option A, valvulus, intestinal valvulus, or option B, testicular atrophy, option C, duodenal atresia or Hirschsprung's disease. Please choose that if it's Down syndrome, okay? And of course, most of them are predisposed to leukemia, ALL. Majority of them will end up with acute lymphoblastic leukemia. And if they grow older, if they happen to grow more older, they'll end up with Alzheimer's disease in their late 30s. Okay, so this is how it is. And yes, and also have umbilical hernia, okay, and congenital heart defect. So we'll be talking about the congenital heart defect soon. And yeah, so let's look at the key characteristics of Down syndrome. Okay, so we have the upslanting palpable fissures, the low set ears folded, short neck, epicanthal folds, which are the upper eyelid skin folds that cover the inner corner of the eye. We also have the flattened nasal bridge, the brush-filled spots, which are small, typically white spots arranged in a ring. Okay, so these are key facial characteristics of Down syndrome. So kindly take notice of these. So this is a real baby with a flattened nasal bridge, epicanthal folds, brush-filled borders, brush-filled spots, sorry. Okay, all right. And you can see a prominent tongue. Okay, and that is the palmar crease of a real baby. So you can see one crease. You can look at your palm. Your palms end like this. Okay, so look at this one also. This is a palmar crease of a real baby. All right, Down syndrome. Yes. So this is one crease called the Palmer crease, or sometimes we can have a double called the simian crease. Okay, simian crease is all characteristic of Down syndrome patients. Okay, and the heart deformity. This is not cardiology lesson, but we have to look at cardiology, normal heart, the cardiovascular system for now. We have the pulmonary valves, of course, the right atrium, the inferior vena cava, the right ventricles, left ventricles, and of course we have our ventricular septum. Okay, ventricular septum and the aortic valve, and so on and so forth. Okay, and that reminds me, you have to master all your mesoderms, your surface ectoderm, your neuroectoderm, your neural crest, and your etc. And this is a neural crest migration defect we're talking about here. So this is Down syndrome patient without a septum. Ventricular septal defect normally is what they classify as endocardial Cushing defect. Okay, so that is a neural crest migration defect. They can ask you that question too, so take notice of it. Okay, so of course they'll end up with VSD, whereby deoxygenated blood mixed with oxygenated blood, and of course this is very huge, VSD, so the baby is going to be cyanotic. Okay, so take notice of this. They need surgical repair. So this is classic. This is a real heart. We have our right atrium, our right ventricles, right atrium, right ventricles, and of course here between the right atrium and the right ventricles we have our AVSD, which is the atrioventricular septal defect, and of course they need repair surgically. All right, so take notice of this. All right, so looking at the karyotype, it's 47XY instead of the 46XY. Why? Because there is an additional 21. Every chromosome is 2, homologous chromosome, but the 21 here is 3 now. That makes it trisomy 21. If it's Edward, it's going to be 18 trisomy. If it's Patel, it's going to be 13 trisomy. Now we're talking about Down syndrome, it is 21 trisomy. Okay. Now, Robertsonian translocation is something that is diagnostic of Down syndrome. Whenever you see that on the answer options, and of course we know the classic cause to be maternal non-disjunction, and if you don't find non-disjunction and you see Robertsonian translocation, please pick it, because in about 4 to 5% of the cases, especially with mothers younger than 30 years of age, their babies with Down syndrome end up as a result of Robertsonian translocation between chromosome 14 and chromosome 21. Ladies and gentlemen, so this is chromosome Robertsonian before translocation and after translocation. Okay, it's like the 14 breaking off to join the chromosome 21. So Robertsonian, this is how it arises. You have 2 normal pairs of chromosome. We have these 2 pairs of chromosome, and now one breaking off to join the other. Okay, 14 breaking off to join the 21. Okay, and now we're gonna have 21 trisomy here, 21 trisomy here. So this is Robertsonian translocation between chromosome 14 and 21, making 21 a trisomy, Down syndrome. Okay, so let's look at the normal cell division here. We have an egg. Of course, the egg is a 23 chromosome and the sperm is a 23 chromosome. Okay, so after fertilization, then what happens? You now forming a baby, it's a zygote, so it becomes a 46 chromosome now, and 46 chromosome mitosis. So mitosis now, we have our 46. Okay, it's split into 2, another 46 split into 2, become 46 again, and also another 46 here. Okay, so this is the normal cell division as we know it. So the egg is 23 chromosomes and the sperm is 23 chromosomes to start with before fertilization. So a non-disjunction, this is the problem with all Down syndrome, majority of the cases. I just told you about Robertsonian. Robertsonian comprises of about 3 to 5%, but in more than 95% of the situation, it's a maternal non-disjunction. Maternal, that means it's in the egg and not the sperm. Okay, so a non-disjunction is the failure of homologous chromosomes to separate properly during meiosis. So what should happen? This is what should happen. You see the yellow and the blue. Okay, so we have the yellow and the blue. So the yellow splits into 2 and the blue splits into 2. Okay, non-disjunction whereby the yellow splits but the blue doesn't split into 2. Okay, all the 2 goes into 1. So this means it's a non-disjunction. It's a failure of homologous chromosomes to separate properly during meiosis. Okay, so let's look at it in this form. In trisomy here, we have the egg, so that makes it maternal. It's a maternal non-disjunction. A maternal non-disjunction is not only in trisomy 21, it can also happen in patau, trisomy 13, and also the other trisomy, Edwards syndrome, trisomy 18. Okay, so the egg having 46 chromosomes. Now, the 23 is empty, so here becomes 24. But if you look at the sperm, it's split into 23, 23. So there's a non-disjunction here in meiosis 1. Okay, so now it becomes 47 chromosomes, non-disjunction, and now 47, 47 instead of the 46. That is a trisomy. So this is trisomy 21. Let's look at this non-disjunction once again. Meiosis 1. Non-disjunction during meiosis 1. It doesn't really split well. Okay? You can see the first one here. The blue and the red. It splits. Here, only 2 here. But at the top, you can see 1, 2, 3. 1, 2, 3, 6. Okay? So thereby, as a result of the non-disjunction, we don't have an even distribution. So we have n plus 1, n plus 1. Instead of 2, 2, 2, 2, there is 3, 3, 1, 1. Okay? And n plus 1, n minus 1, n. Okay? So this is a non-disjunction. So let's look at non-disjunction in meiosis 1. Again, non-disjunction here. You can see, so n plus 1 as a result, n plus 1, n minus 1, n minus 1. So here becomes 3 at the end, and here becomes 1, 1. But it's supposed to be 2, 2, 2, 2. So the number of chromosomes have changed, ladies and gentlemen. So now this is trisomy 21 as a result. This is a karyotype for you to know. So let's go on to our question. All right. So a defect in which step of cell division is most likely cause of the patient's defect? Okay, and the answer is what? It's meiosis 1 of anaphase. Meiosis 1 of anaphase, and it's as a result of what? Maternal non-disjunction in the anaphase. Okay, all right, so this is our Down syndrome patient, as you can see. And if you didn't really understand the whole process, you can go back and listen again to the video. You can see the process of the anaphase, the process of the non-disjunction, and everything. But the answer is meiosis 1 of anaphase. And the problem is a non-disjunction, like I showed you here. This is non-disjunction, making it a trisomy here. N plus 1, n plus 1. Non-disjunction, meiosis 1. Meiosis 1 non-disjunction, and it's maternal. Is the egg here? I showed you the egg. It's maternal non-disjunction. This is the reason why, and it's meiosis 1 of anaphase and not metaphase and not prophase. Okay, it's anaphase. All right, so take notice of this. And these are some of our Down syndrome patients. We love you all, Down syndrome patients. We appreciate every Down syndrome. This is a cute baby. Wow, nice, beautiful. Okay. Down syndrome, you can see the flattened nasal bridge and low set ears, you know, and you can see the neck, short neck. They have a peculiar face, if you can see that, the nuchal folds, etc. You can see nice smile, very nice smile here, you know. Thank you very much for joining me once again, and I'm very happy to take you through trisomy 21, Down syndrome, and I'm glad that you're able to join me and finish this lesson with me. This is 100% board exam USMLE questions. Dr. Kevin Marnu, USMLE exam series, and I'll be back again next time for another wonderful lecture. Thank you for your time, and God bless you. And to all our Down syndrome patients, we love y'all. All right, God be with you. Welcome back. This is episode 3 of 100% USMLE board exam questions. Okay, and I'm happy to always be here to assist you. Today's episode is gonna be great because well, this is my new page, Dr. Kevin Marnu, USMLE, and If today is your first time, my name is Dr. Kevin OBENG-Marnu. That's my page here, and you can find me here anytime. And anytime, feel free to contact me. You can message me, and we do a lot. So I'm also a neurosurgeon, so I have my personal neurosurgery page here, and feel free to contact me anytime. All right, and yeah. So without further ado, today's lesson is gonna be very, very great. That's my profile, my personal profile here. And for all those that enjoy using Instagram, you can also find me here on the Instagram. And yes, so we do a lot. We do a whole lot, and we help a whole lot of people also. So anytime, we have so many lessons that we help a lot of people with. So if you also want to come for one-on-one lessons, be my guest. All right, so we do a lot. All right, we do a whole lot. So yes, anytime you can let me know. All right, so like I said, today's lesson is going to be great because it consists of biochemistry and hematology and dermatology all combined. Okay, so let's get into it. Let's not waste too much time. Okay, so let's go. A 50-year-old man comes to his primary care physician because of chronic blistering, itchy skin over his forearms. Laboratory records show that the patient has a long-standing history of mild elevation of transaminases in blood. The patient reports that his urine is tea-colored. On examination, there are small tense vesicles, bullae, and erosions over the dorsal aspect of both forearms and hands, in which cellular compartment is defective. Is the defective enzyme most likely located? And they really love this kind of question. Okay, no matter what, you're gonna answer this kind of question. A, mitochondria and cytoplasm. B, mitochondria only. C, nucleus. D, rough endoplasmic reticulum. E, cytoplasm. Okay, and without further ado, this patient has what we call Porphyria Cutanea Tarda. Okay, Porphyria Cutanea Tarda. All right, so I'm going to explain to you why it's Porphyria Cutanea Tarda, and I'm going to explain the answer to you. Okay, and they really love this. All right, so you can see the patient here, the erosions, all right, that they mentioned in the question, and also the blisters that they mentioned in the question on the hands and the forearms. Okay, so, and also hypopigmentation. All right, you can see with this patient also, you can see erosions on the hands. All right, and hypopigmentation. With this, you can see the blisters. There's a blister here which is very, very prominent blister. Also erosions here, and a little hypopigmentation. With this patient, you can see the hypopigmentation very clearly. All right, and yes, you can see the blisters here in this patient. All right, so this is Porphyria Cutanea Tarda. All right, you can see this also. They really love this. They love Porphyria Cutanea Tarda. They love acute intermittent porphyria, and I'll show you the difference real soon. All right, so this is a Japanese. This is one of the early Japanese to be recorded to have familiar Porphyria Cutanea Tarda. So this is a real record I'm showing you here, real research record, and you can see the erosions. You know, yes. Look at this patient. See the blister, and you can see hypopigmentation and also erosions, what they classify as erosions. It's very, very clear. And look at this patient also. By the ear is very, very prominent here by the ear. All right. Oh my God. Woo. 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 Don't panic. I want to panic. Don't panic. Okay, this is biochemistry. I'm gonna take you through. Don't panic. Okay, it looks scary. It looks scary. Don't panic. Okay, so heme synthesis. Let's get serious. Come on, let's get serious. They really love this. I'm gonna tell you there are about 6 questions here, 5 questions, maybe 10 questions here, maybe a lot of questions here. The cofactors, lead poisoning, sideroblastic anemia, acute intermittent porphyria. Look at the diseases here. See a lot. X-linked proto-porphyria. You see, aldehydrates deficiency porphyria, acute intermittent porphyria, congenital erythropoietic porphyria, Porphyria Cutanea Tarda, hereditary corporal porphyria, you see, variegate porphyria, protoporphyria, a lot of diseases here, just the heme synthesis alone, okay? Heme, iron, okay? You think of heme, you think of iron, hemochromatosis, and all those diseases, okay? Heme, all right, to create or to form hemoglobin, all right? So, how do we get heme? All right, how do we get heme? So heme starts with succinyl-CoA and glycine here at the top. So it says succinyl-CoA and glycine. Then what happened next? We have ALA synthase. The ALA means delta amino levulinic acid, okay? So synthase means to synthesize, okay? So we synthesize that. Then we have the porphobilinogen, okay? All right, we synthesize that to have the delta amino levulinic acid. Then we have the dehydratase to porphobilinogen, okay? Dehydratase to porphobilinogen. And from then, porphobilinogen, we have an enzyme called porphobilinogen deaminase, okay? Deaminase to hydroxymethylbilane. Hydroxymethylbilane. Then what happened next? Okay, now another synthase to synthesize. What are we going to synthesize? We're going to synthesize uroporphrinogen 3. Uroporphrinogen. So what do we need? We need uroporphrinogen synthase. Okay, so we synthesize to get in order to get uroporphrinogen 3, we need uroporphrinogen synthase. All right, so we have the uroporphrinogen 3. And now what do? Decarboxylase. Okay, decarboxylase. So from uro, we're going to corporal-porphrinogen 3. All right, so after we get that through the uroporphrinogen decarboxylase, now we have the corporal-porphrinogen 3. What do? We have to oxidize. So oxidase. So corporal-porphrinogen oxidase is going to give us proto-porphrinogen, okay? Proto-porphrinogen 9. Then after that, we have to oxidize again. So proto-porphrinogen oxidase again. We're going to have proto-porphyrin 9. And now ferrochelatase to heme. This is very, very important. The ferrochelatase is important because of lead poisoning. Lead poisoning attacks 2 enzymes. One is aldehydrates. Remember this for your exams. Aldehydrates, which is amino levulinic acid, delta amino levulinic acid, dehydratase, and ferrochelatase. Okay? Remember that. And they like to trick you on the exams. On the exams, they will put synthase and aldehydrates for lead poisoning. Remember, it is not synthase. It is aldehydrates. Don't get confused. They can put option A, amino levulinic acid synthase. Option B, amino levulinic acid dehydratase. Okay? And it's lead poisoning. You know it's lead poisoning, but you're going to choose synthase is wrong. Okay, synthase is sideroblastic anemia. Synthase for sideroblastic anemia. Okay, X-linked diseases. We have X-linked protoporphyrin. Okay, protoporphyria. All right, that is a different issue. Lead poisoning is aldehydrates and ferrochelatase. Okay, we'll come back to that on a better day when we're talking about lead poisoning. All right. And now we have acute intermittent porphyria. You can see that is porpho. This one I mean here. That is porphobilinogen bilinogen deaminase. They really love this a lot, okay? And check it out. Once that enzyme is inhibited, that means the whole pathway cannot proceed. So if porphobilinogen deaminase is inhibited, what is going to happen? We cannot get to hydroxymethylbilane. That means porphobilinogen is going to back up. We're going to have lots and lots and lots of it. So they can also ask you that. They love these kind of questions. That is why I keep stressing on it. They can ask you what is backed up, okay? Or lead poisoning, what is backed up? What is backed up is delta amino levulinic acid. If aldehyde is inhibited, that means we cannot move from delta amino levulinic acid to porphobilinogen. And if the patient has acute intermittent porphyria and porphobilinogen deaminase is inhibited or is deficient, okay? This is deficient. If it's deficient, that means porphobilinogen is backed up. We have lots and lots and lots of that. We cannot proceed down the line, okay? So this is one way they love to ask. And again, they love to ask of the cofactors and all that, okay? So from heme, we go to heme, oxygenase to biliverdin plus carbon monoxide and iron, okay? Bilirubin, and also we have our cytochrome P450. That is why in the patient had liver transaminases, okay? Yes, they had high levels of transaminases because these kind of diseases, porphyria, can cause liver cancer and also liver cirrhosis, etc. Okay, so we will come back to that. Let's look at another one. Remember, we have some of these in the cytoplasm and some of these also in the mitochondria. Look at this. The green is the mitochondria, okay? So all that we've seen, these enzymes are found in the mitochondria, all right? These enzymes are found in, so that means succinyl-CoA and glycine starts in the mitochondria before they get to the 5-amino levulinic acid. The allosynthetase, the beginning, is found in the mitochondria. Aldehyde is found in the cytoplasm. All these enzymes are found in the cytoplasm. All these are found in the cytoplasm, okay? The uroporphyrinogen 3 to coproporphyrinogen 3 and the uroporphyrinogen synthase and all that, aldehyde, these are all found in the cytoplasm, okay? They're all found, and these are all found in the mitochondria, in the ferrochelatase, the protoporphyrinogen oxidase. All these are found in the mito. Okay, if this image is not clear, let me show you a better one. Okay, look at this one here. Okay, if we look at this one here, clearly we have these in the cytoplasm. I told you about lead poisoning, right? And that is 2, number 2. You can find the number 2 here. And the number 2 is the aminolevulinic dehydratase. It's the same as aminolevulinic acid dehydratase. The same. You can say aminolevulinate dehydratase or levulinic acid dehydratase, okay? So 2, okay, that is lead poisoning. Also number 7 is lead poisoning. Where is number 7? You find number 7 here, from protoporphyrin to heme, ferrochelatase is inhibited by lead poisoning. Take notice of this, okay? And of course, glycine and succinyl-CoA is inhibited by glucose. That is for another day. But if you look at the mitochondria here, the only enzymes we have here, ferrochelatase, number 7, and number 6 is what? Coproporphyrinogen oxidase, okay? Besides that, almost all are found in the cytoplasm, okay? Almost all are found in the cytoplasm. Take notice. From the first lead poisoning, which is the dehydratase, aldehyde, and also for the diseases such as acute intermittent porphyria, that is the deaminase, right? Number 3 is the porphobilinogen deaminase, okay? Porphobilinogen deaminase. And also number 4, from hydroxymethylbilane to uroporphyrogen 3, okay? That means we are going to means it's urosynthase, okay? Uroporphyrogen 3 synthase is all found there. What about number 5? Number 5 is also found there, the decarboxylase. And this is where we have our Porphyria Cutanea Tarda. This is our disease we are learning here. Our disease we are learning here is Porphyria Cutanea Tarda, okay? And the reaction is uroporphyrogen 3 to coproporphyrogen 3. And the enzyme is number 5, which is uroporphyrogen decarboxylase. And that is found in the cytoplasm. So we've answered the question. Yes, we've answered the question. We have answered our question, okay? Yes, we can go back and answer the question. We have answered the question, okay? If you read everything, blistering on the forearms and T-colored and blisters, etc. And the answer is option E, cytoplasm. Yes, option E, cytoplasm. But let's look at more. Okay? All right, so this is cytoplasm. They really love this. But let's look at more. All right, so it's the same here. Mitochondria, it starts with glycine plus succinyl-CoA. Then we have the synthase. I told you the synthase, sideroblastic anemia. Okay, it's X-linked disease. Then we go to aminolevulinic acid, and the dehydratase is where the lead poisoning is. Okay, then we go to all here is the cytosol, which is the cytoplasm. Only here the blue color is the mitochondria. Okay, this is the mitochondria, and we have the ferrochelatase and the protoporphyrogen oxidase. Okay, we don't have a lot in the mitochondria, and the aminolevulinic acid synthase in the mitochondria. The rest are all here in the cytoplasm. Okay, so you can have time and memorize these or not memorize. You can just understand the reaction and understand the principles of it. Okay, it's the same thing here, the same thing in this diagram. The pink is the mitochondria and the blue is cytosol. Okay, so the pink at the top, what do we have? We have the allosynthes. Okay, allosynthes, and the red here we have the protoporphyrogen. I told you it's not a lot, it's about 3. 1, 2, 3, 4. It's about 4 enzymes there. Okay, coproporphyrogen oxidase and protoporphyrogen oxidase and ferrochelatase. Okay, and just take notice of all these. And there are a lot of diseases here. We have X-linked dominant, okay, protoporphyria, aldehyde deficiency, porphyria, acute intermittent porphyria is very, very important, and a classic disease that they really love, which is the porphobilinogen deaminase. Okay, so take notice of it. Congenital erythropoietic porphyria also is the uroporphyrogen 3 synthase. Okay, and also the Porphyria Cutanea Tarda, which is our disease here under study, is the uroporphyrogen 3 to coproporphyrogen 3, which is Porphyria Cutanea Tarda. And also we have the hereditary coproporphyria, and we also have the variegate porphyria, okay, which is the protoporphyrogen 9 to protoporphyrin 9. Okay, so over here is the same thing. The dark colored, the black colored is the mitochondria, and of course the light colored is the cytosol. Is the same thing, starting from glycine plus succinyl-CoA. And I told you glycine and succinyl-CoA is inhibited by glucose. Okay, so you can take notice of that. And the cofactor for the ferrochelatase is iron as the cofactor. So take notice of this as well. With acute intermittent porphyria, we have the 5 P's. Okay, that is a different disease. It's not this question we solving here. This is a different disease. And the mnemonic you can remember is the 5 P's. If you read it, listen to this carefully. If you read the question and you're not sure whether it's acute intermittent porphyria or is Porphyria Cutanea Tarda, just remember the 5 P's for acute intermittent porphyria, which is number 1 P is the pain in abdomen, number 2 P is the polyneuropathy, number 3 is the psychological abnormalities like hallucinations and all that, okay? And also P for pink urine, or the P blood, it's like a tea colored pink urine. And P is precipitated by medicine, sulfur containing medicine like sulfonamides and other sulfur drugs, barbiturates, etc. Okay, so remember the 5 P's. If you read a question and there is no psychological disturbances, there is no pain in abdomen, there is no precipitated by phenobarbital or barbiturates or sulfonamides, please don't choose acute intermittent porphyria, okay? All right, so yes, this is a patient with acute intermittent porphyria. You can see a lot, all right? Attacks can be precipitated by various drugs and etc. They also have hyponatremia, hypokalemia, psychosis. You see psychosis and odd behavior, seizures and all that, okay? All right, so yes, this is a patient with, and photosensitivity is Cutanea Tarda, okay? Cutanea Tarda, yes, photosensitivity with that is quite different from acute intermittent porphyria, okay? So take notice of all this. So it's well asked, very, very classic. And yes, okay, so conclusively you can see peripheral nervous system, the limbs, the weakness or pain, and the numbness, and etc. The tiredness, paralysis, and respiratory disturbances, and the gastrointestinal, also constipation or diarrhea, autonomic nervous system, etc. Other reddish stool, reddish urine, and the low blood sodium, and also central nervous system, confusion, anxiety, seizures, insomnia, hallucination, depression, etc. Okay, so take notice of that. Conclusively, porphyria, dysfunction of the peripheral nerves, also hallucination, seizures, coma, skin diseases, photosensitivity, blistering sores, okay, abdominal pain, intestinal pseudo obstruction, okay? All right, so take notice of the tachycardia, of course, and hypertension, also changing color of urine. All right, so how do you treat acute intermittent? All right, always, okay, you can give IV panhematin, which is to decrease the porphobilinogen levels, okay? It's IV heme, okay? All right, so you can also administer fluids and antiemetics, analgesics, and anti-seizure drugs. Also gene therapy, okay, because these are enzyme deficiencies. Okay, so you can give your gene therapy. Also liver transplant, so because they have a problem with the liver, at the end of the day, they can end up with liver cancer, liver cirrhosis, siRNA of the delta aminolevulinic acid synthase 1, okay? And these are some of the medications you can give for acute porphyria. A lot are unsafe, phenytoin unsafe, barbiturates unsafe, okay? Valproic acid is unsafe, carbamazepine is unsafe, okay? Some of it are unsafe, and some are quite safe, and propofol and ketamine and gabapentin, lorazepam, etc. Okay, with Porphyria Cutanea Tarda, you can also give anti-malaria medication, okay, like hydroxychloroquine and chloroquine, and you can also discontinue any medications or any drug which is precipitating the disease, okay? And yeah, so yeah, this is a patient with Porphyria Cutanea Tarda. Okay, you can see hypopigmentation and also erosions on the skin. And yeah, with that being said, thank you very much for joining me once again. And if you want to contact me for a one-on-one lesson tutorials, I'm always available. And I wish you well, and study smart for your USMLE, and always buzz me up whenever you have any problems. Okay, all right, God bless.
Ladies and gentlemen, I'm Dr. Kevin OBENG-Marnu, a practicing neurosurgeon.
This is Dr. Kevin OBENG-Marnu, MD. Welcome to my channel. Subscribe, like, comment, and share. And God bless. Thank you.